Okay, we're now live on Facebook and we have about 3 minutes until 2. And as soon as it's 2, Patty, you can start.
Well, welcome everyone to a three-part series beginning today with part 1, a multidisciplinary perspective on the disproportionate impact of COVID-19, a case study. We will experience an interprofessional dialogue between social work, nursing, and public health. Thank you all for joining us today via Zoom and Facebook. My name is Dr. Patty Allard, and I'm lead teacher in the University of Texas Arlington College of Nursing and Health Innovations in the undergraduate program. I'll be your moderator for today's events. Well, let's do a little housekeeping first related to our CEs and other information. I will share my screen with you momentarily. Oh. I need my screen opened. I'll read this to you until that happens. I cannot share at this moment. Can somebody help me with that?
You should be good now, Patty. Sorry.
Awesome, I am good. Excellent. Is everyone able to see that? So this is the topic that we have is the multidisciplinary perspective on the disproportionate impact of COVID-19 in a case study. The University of Texas at Arlington College of Nursing and Health Innovations is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Commission on Accreditation. University of Texas at Arlington School of Social Work is authorized to provide CEUs for social workers. This activity's nurse planner has determined that no one who has the ability to control the content of this continuing nursing education activity, planning committee members, presenters, authors, none of them have a conflict of interest. The University of Texas Arlington College of Nursing and Health Innovation is the provider of this activity. UTA School of Social Work participated in the joint planning of this activity. This activity has received no commercial support. To receive 2.75 contact hours for this professional development activity, complete the pre-work, join the live virtual presentation, attend the entire activity, actively participate in discussion, complete and submit a post-activity evaluation. The link is here and will also be in the chat at the end of the program. Learning outcomes. 65% of participants will report that this activity provides information that enhances, validates, or causes a change in practice. For nursing CNE questions, comments, concerns, please email Becky Baird, nurse planner, at becky.baird@uta.edu. Or for social work, CEU questions, comments, concerns, please email Tracy Orwig, Social Work Planning Committee, at tracy.orwig@uta.edu. Now, let me stop sharing that and get you to the next little tidbit. We are, there's going to be a question and answer immediately following all of the presenters. And please email Tracy Orwig, as I mentioned on that slide. If you have not received the pre-work materials, we'll also make sure her information is posted in the chat. Now to our excellent presenters. Dr. Crutchfield, will you begin to introduce yourself, and each presenter will introduce themselves as well. Thank you.
Thank you so much, Patty. Hi, everyone. Thanks for joining us today. My name is Dr. Jandell Crutchfield. I'm currently an assistant professor in the UTA School of Social Work. I'm in the middle of my third year here, and I currently am studying racial justice, mainly in the public school setting. And I also have expanded recently to look at health settings and other sectors of society. And also exploring the training effectiveness for anti-racist practice among social workers, other healthcare professionals, and helping professionals. Outside of work, I'm a wife of almost 15 years this year, a mother of two, a son, JC, who's 8, and a daughter, Malaika, who's 6. And so I'm just excited today to be with my co-presenters and everyone joining to tackle these big issues from a multidisciplinary perspective.
Hello, I'm Margarita Trevino, and I am serving at UTA as associate professor, clinical professor, and a member of the administrative team. I've been at the college for 10 years, and my clinical specialty is community health nursing. I'm from this area and have had the opportunity to practice in community health, so it's dear to my heart, and I appreciate the opportunity to share some perspectives with you today. Thank you.
Hello, I'm Erin Carlson, and I'm Associate Clinical Professor at the University of Texas at Arlington in the College of Nursing and Health Innovation at the Department of Kinesiology. And my role is Director of Graduate Public Health Programs. I'm delighted to be here with you today. My background, one of the reasons I'm so passionate about everything going on right now, my background is infectious disease research, as well as access to care for marginalized and vulnerable communities. So there's a lot of what we're going to be talking about, which really highlights some of the things that we've seen for years. So very delighted to be here and to have the chance to present along with my esteemed co-presenter. So thank you so much for this opportunity.
Would you like us to go ahead and get started, Patty? Is that next on the agenda? Yes. Good. All right. Okay, so thanks for introductions again. And so everybody, you guys know that COVID-19 has consumed, right, our global society for over a year now. It's encompassing everything we've done, are doing, including holding this presentation virtually, right? So to all those who are impacted personally, professionally, socially, we're sharing in that same journey with you, and we are hoping that there are brighter days ahead. So we join you in that hope. So many of us have been touched personally. We thank you guys for joining again. If nothing else, you guys probably have at least compassion on those who have been uniquely impacted by COVID. But for a lot of you, it actually has personally impacted you, the way you work, the way you learn, right? The way you and your families are living. And so it's our belief today, what we'd like to offer you is that to tackle the big issues like COVID-19 in healthcare, we believe interprofessional education or the IPE approach to COVID, including social work, community health, nursing, and public health, is what's going to be ultimately effective. So let me get back to the next slide. So learning together and working together is central to IPE. And so I'd like actually for those who are on to use that chat a little bit, because again, we will be opening it up to questions later. So we want to make sure you guys know how to use the chat. By now, all the virtual things happening, I'm sure folks do. But on a scale of 1 to 3, with 1 being, I've never heard of IPE ever. 2 being, I'm somewhat familiar with IPE, interprofessional education. And then 3, you know the book, right? Would you guys in the chat share with us how familiar you are with IPE? We know that out there's students with us. We know there may be, of course, health professionals, faculty, staff, community members. So we'd love to kind of read the audience and see where you guys are. So let's see. I see lots of responses coming into the chat. Great. So a lot of people around 1 or 2. I see a few 3s. So lots of people kind of around on 1 too. That's interesting. And I think that gives us some leeway to kind of just talk about IPE, right? People are representing IPE. Tracy's getting a shout out. Okay, so lots of 1s I'm seeing. So I'm glad I asked that question because as we talk about IPE, we need to know what it is, right? And so interprofessional education generally just refers to the opportunities for students from 2 or more professions in health and social care, so like social work, to learn together during all, sometimes, or just part of their professional training. And so the objective with IPE is to cultivate collaborative practice for patient care. And so that's what we're trying to model for you today. And the reason interprofessional practice might make sense is that teamwork in healthcare is the way to solve big issues. And I think we mentioned that. So the goal of IPE, interprofessional education, is to prepare health professional students with knowledge. They need skills. They have to have the right attitudes to collaborate, right, to get things done. And so I'm sure for those of you guys out there, you understand the need for it. It's really near and dear to my heart. As a social worker, I've practiced in schools, like I said, in education. And so I've led some of the cross-training efforts because people actually need to kind of know what another professional might do to help them be able to do their job even better. So today's presentation, I'm flipping back and forth between screens, sorry, is a practical application of IPE to a case study of a patient who died due to complications of COVID-19. So we'll demonstrate, my colleagues and I, to you how we would view the key components of her case from 3 respective professions, right? So what is it that social workers would highlight in reviewing this case of a family COVID situation? What would community health nurses, what would their perspective be? What would they push to the forefront as those key things to consider? And then finally, how would this case be explored from a public health perspective? So Margarita, Aaron, and I are bringing this case review to you. And so we hope that you're able to see us in action. You guys see we're in the same room. You see that UTA background, right? So we're in the same room together virtually. And so we are going to hopefully give you guys some takeaways for your practice. So let's see, going back to this slide. All right, so as a social worker in the room right now, Margarita and Aaron, we have to just kind of put things in context, right? The world that we're living in right now, because of COVID, this caused some hardships. And I think this is the case particularly for our family, right? This patient. And so we're looking at this patient as a 71-year-old African-American woman. What might we consider about her situation? That really is the perspective of social work, is what's in context, right? Lots of things can be taken out of context. But as a social worker, what I'd offer really is that this is not just one patient in one hospital, in one family, right? She's part of the larger systems that unfortunately have historically given disproportional care to people like her and has led to sometimes devastating outcomes and impacts for the African American community in particular. And so I always would bring that to bear as we're talking about this one particular person. And so on the slides here, we have to think about the national disproportionality when it comes to how many more times an African American person or a Latinx person or an Indigenous person is to be hospitalized due to COVID or to die due to COVID than a white person, right? So the idea of disproportionality meaning the representation of hospitalizations is much larger than what's represented in the population for that group, right? So if you're looking at the charts here, African Americans in particular are multiple times more likely to be hospitalized and die due to COVID-19. And so that's the case with our 71-year-old patient here. So we can't look at this and wonder, you know, what is it about this particular patient? There's lots of things going on broader when we talk about African Americans in this disproportionality. So
could I get you to put the screen in full screen? There's a few people who can't see the slide.
okay, sure.
Thank you.
I'm not able to see notes here when I do that, so I'm going to try my best to get back to this. Sorry, everyone, I have multiple screens here. All right. I don't see that as my Teams. Does anybody else hear that? I hear a Teams call right now. Does anybody else hear that? Trying to think. I don't see.
I do hear that.
You do hear that? Okay.
It was from Valerie.
Okay, from Valerie. Okay. Is there a way to stop that sound? So if you're not muted, maybe mute. There we go. All right, we got it. The famous, right, mute. All right, so let me go into full screen here and see how this works. Sorry, everyone. Thanks for being willing to. I'm still hearing that. I'm just trying to make sure that's not me in terms of the sound here. I keep hearing a Teams call. Okay, let's try to keep going. So we're talking about nationally, this disproportionality. In Texas, the disproportionality, let's see. So I believe you can mute all participants. Let me try to do that. I think everybody's muted now. so we can hear my voice and I'm not getting a Teams call here. All right, so this is larger. So I think I have to, because of the way my screen is set up, unfortunately, I have to have this be a bit smaller. So I will try to maximize it in the screen. But I'm not able to have it run as the slideshow. So let me just see if I can maximize each slide. Okay, so as I was saying, nationally, considering the context of COVID for our client, right? So she's not outside of the context of disproportionality. National statistics, again, represented here. In Texas, though, there's still some disproportionality. I think it's a bit lower for African Americans. So African Americans in Texas are 12% of the population, but represent about 16.7% of those cases of COVID, right? So there again is that disproportionality. You would expect to see something around 12%. And for the Latinx population, it's even more astronomical, right? Representing about 14% of the population, but 38.2% of the cases. And so when we think about COVID, we think about that continuum of care, which our patient is existing in. And so it's not just limited to the cases. Right now, thankfully, there are vaccines available, but then there are also disproportionality when it comes to the uptake and the spread of the vaccines throughout the community. So I think even 2 times more likely, right, for a white patient or white resident to be able to get access to a vaccine. So if you think about the numbers, right, we want to put our patient in context. We can say that 1 in 735 African Americans have died due to COVID. 1 in 595 Indigenous people have died due to COVID. 1 in 895 Pacific Islanders have died due to COVID. 1 in 1,000 Latinx people have died due to COVID. 1 in 1,030 whites have died, and then 1 in 1,670 Asians have died. All right. And so our case is situated within a range of those interactions in healthcare, where studies demonstrate how people of color experience discrimination. So even at emergency rooms, departments being shifted around, kind of waiting for hours longer than white family, potentially not being believed about their own symptoms, being perceived to have this higher pain tolerance or thresholds, so not being given kind of life-saving meds or pain meds. Now that there is this kind of mass vaccine distribution effort, the same healthcare system that has been plagued with the lack of quality treatment for African Americans continues to see that disproportionality with vaccines. And so there are some deeply institutional flaws in the treatment for African American people. And all of this is what surrounds our patients. And so this is my representation of our 71-year-old patient, a beautiful woman here who's sitting with groceries and talking, right? And so I'm not sure what access everyone has had to this particular case study, but this 71-year-old African-American woman is a widow, retired school teacher. She felt weak and unwell for 2 days, came to the emergency department through an ambulance, decreased eating, had some fainting episodes, 12 hours. She had diarrhea on the day that she came to the ER. So her health history is that she was admitted to the emergency department internal medicine unit for further observation and care. She had a medical history of breast cancer 5 years prior. She had a status post mastectomy and radiation. She had a history of heart failure. And so she's had a recent cardiac stress test. The results were negative. And in the emergency department, the patient's body temperature was 100.4, blood pressure 118/64. And so those are some of the health history. And so a really important portion of what social work kind of would be focused on are called psychosocial family issues, right? And so I know if you're in a hospital setting, you understand what that means, but things outside of necessarily her biology or her physical health. And so our patient had been self-quarantined at home with her asymptomatic COVID-19 positive older adult, her elderly sister. Her granddaughter is 36, is living with her with a 16-year-old, 12-year-old, 10-year-old, a 4-year-old, moved in with our patient after several weeks of being laid off from her job. And so she became homeless and had to move in with our patient. And so now the granddaughter's homeschooling, right? So those are the facts of her case. And so the perspective that we use in social work is something that considers how all of those things are interrelated, right? So we can't look at one aspect of our client's situation without looking at another. Community health nursing, public health have unique perspectives. Social work uses a systems perspective, right? And so the main idea about that is multiple things are happening at the same time, right? Multiple interactions are happening between these various systems, and I'll go over what each of these systems means. So individuals, systems, and the environments of those individuals are constantly changing and adapting to each other. based on what's occurring in the other systems. So this perspective includes some portions of other theories, but that main idea, the main concept is that you have to address things in multiple systems for there to be some type of progress. And so if we think about disproportionality with our client in particular, addressing those racial disparities has to be part of what we're doing when we serve her. And so whether that is through the climates of hospitals, whether that is through policy, lots of different things, we have to be able to look at all of those. So let's see. All right, so let's talk about the microsystem here. I'm not sure folks are able to see the microsystem. So I read a bit about her. And so we just want to highlight a few of the things about her in the microsystem, which means it's the client and their immediate surroundings. So home, school, work, those things, right? So we know she's retired. There's a school teacher there. We know she's not working. So we're not sure about her income. What is home like right now? As a widow, what does that manifest in terms of her health or her relationships, her well-being right now? She's self-quarantined. She has an older sister that is COVID-19 positive. Additionally, now she has in the home with her 5 other people. Right. So her granddaughter and the granddaughter's children have now moved in. So her home has recently changed a lot. And so potentially breaking down some of the protections that she's had without having exposure to extra family members. And at the micro level, right, these are things that aren't often brought in with the client. So her grandchildren, her great-grandchildren actually may not come in with her, but they are with her. And so I think that's a unique perspective in terms of what social work is saying. They're always with her, whether we could see them or not. And so then the meso system is the interactions. Remember that word, interactions, between everything happening at home, right? So maybe she has a great relationship with her granddaughter and her great grandkids. Maybe she doesn't, right? That could potentially affect her care, her ability to fight an infectious disease, to acquire that. And so the meso is that interaction between the systems of what's happening in the microsystem, right? So between work and home, right? How many people come home from work and kick the dog because of what happened at work? Right, the interactions there, school and home, for her great grandchildren, right, that are learning virtually, being homeschooled. What does that dynamic do with 4 little kids having to be taught by their mom in a small space? Work in school, and we know she's retired, so she's not out working, so there's not that dynamic there. So she has those relationships among the people at home. She might be responsible for some childcare, right? Again, exposure in terms of any infectious disease, COVID-19, other issues. The stressors are potentially there for her as well. Having a stress test, right? And so the potential to have these things increase and be different. So even we in good health, without all of these responsibilities, can see how challenging this is, right? And the amount of stress, even racial stress that can contribute to chronic health problems. Our patient is not a superwoman or superhuman. She is a woman who has all of these things happening in her life. So we'll go on to the Exo System, right? So we see things happening. We have a food bank line. We have folks that are drawing attention to levels of unemployment. We have folks looking for homes. And so again, if we're in the room and we're looking at this case, some of this stuff, it seems so peripheral. But again, the social work perspective is to bring this in and bring this down to the level of the client. And so the Exo System is what's really happening outside of that home. The relationships between a few systems that seem like they really don't matter, right? Like, so what does it matter that, the granddaughter doesn't have a job? At least she's here now. But being laid off for her might limit her ability to get food. She's in the food service line. And so what strain and stress, again, does that put on our 71-year-old patient? So again, this is not the patient, but it still is in the purview. It still is in the systemic life of our patient. Obtaining food for 7 members of the family, a challenge, right, to wait in food bank lines. But this is now part of her ecological system. And so if we're going to just focus on her, that would be, I think, an error in our look at what's all happening with her. So a loss of a job leading to homelessness, leading to being in a food bank line. How is this impacting our 71-year-old patient? And including the disproportionate rates of exposure based on food service jobs, right? So her granddaughter could potentially be more exposed, which makes her more exposed. So those interactions between those systems. All right. So we've got the micro, the meso, the exo. And so our last system is the big system, right? Where all of these things seem so tangential. So meaning, what does this have to do with the fact that, you know, her fever was 100.4 and that she had a stress test that gave this results? The macro system explains a lot of the policy and the institutional structure that are impacting your practice in hospitals, right? Or your practice as social workers, your practice as nurses. And so we all know about policy. Policy are the things we have to follow when we're providing healthcare to people, right? And so for our African-American client, social work looks at the fact that what a lot of people might say is, these disproportionate rates of getting sick, dying, being hospitalized, it has to be something related to African American people, right? Like maybe it's just unique to them, biology, DNA, Latinx people, indigenous people, just something about them. Social work, again, looks at the macro policy level and says, really, it's not race, it's racism that causes a lot of the disproportionality that we see in outcomes for families, for our clients. So lots of people, you know, may think of those inherent things specific to families and leave out the macro system. That's what's, I think, amazingly dynamic about this model. Like, yes, we talked a lot about her specific family, what's going on in her specific home, but we're not going to leave out the fact that she may have encountered a lack of quality care, a lack of preventative care, maybe have limited educational opportunities and access that then leads to poorer healthcare choices, right? And so there actually have been numerous cases, things that have gone viral, right? But actually research-based information too, where African Americans are literally fighting to be treated, right? Even doctors, right? There's a popular case about a doctor who was kind of suggesting maybe this should be some of the treatment. I think I need this, but not being believed, right? Not having access to that preventative care or the types of hospitals that are funded to give the quality treatment that's needed. And so for our patient, right, she still has a family, she is deceased, but all of these things are still impacting her situation, many more African-American patients that we will see. And so I think we have to be able to look at it at all of these different levels. And so that's what I'm bringing to the table for you guys. And Margarita, I know that you might have some similarities to this perspective. You may probably have some differences, but I'm really interested to hear what community mental health, a community health nursing would offer to this perspective here.
Thank you, Jandell, and both you and Aaron. In light of our case study, what I would like to do is identify some of those similarities and differences between African American and Latinx families. Latinx is just a new term to describe Hispanic or Latino that we are perhaps more familiar with, but for the purposes of this conversation, I will tend to use the term Latinx. It's important to recognize that Latinx families are a heterogeneous population group. Their background could be Mexican, Puerto Rican, Cuban, Central American, South American, and any other country where Spanish is the predominant language. The thing that we hold in common are three pillars: love for the family, respect for our elderly, and a preference for Spanish as our primary language. Next slide. One of the things that I found interesting in doing a comparative review of African American and Latinx families were two general designations. Both African American and Latinx families are viewed as marginalized population groups, and this was true before COVID and during COVID. Both African American and Latinx families are suffering the most brutal attack by COVID-19 in terms of morbidity and mortality rates. And Jandell, you did an excellent overview, and I know Aaron will do a more extensive overview of the numbers in terms of lost years of life, etc., as we go forward in this presentation. Next. Now, some of the underlying similarities that predispose both families, again, looking at our case study as well as what we would find in a Latinx community. One of those is the intergenerational households. In Latinx family systems, having more than one generation living together is a norm, and it's okay. We don't frown on a family having, you know, grandma or grandpa or both, and adult children with their children, and so on, grandchildren, and so on. It's a norm, and we consider it to be an okay thing. The problem with that when we think about COVID, though, is that it reduces the opportunity to isolate if that were the need in that family. If any one of the family members were to have contracted COVID-19 and to do the social distancing. So while there's a lot of positivity in that kind of family constellation, they're also setting themselves up for difficulties in combating COVID-19. Unemployment is another parallel to the case study where the granddaughter had lost her job from working in a restaurant. In Latinx families, most of the employment opportunities have been in service areas, essential workers, the people uh, packing our groceries at the grocery store, the persons providing janitorial services in hospitals, in universities, in schools, and so on. These are the kinds of jobs that once you are unemployed, uh, or again, create adversity in terms of lack of income. In the case of the Latinx family, women have been experiencing the higher numbers of unemployment. Across the board, the jobs that Latinx families have held don't provide for sick leave or paid sick leave or any of those commodities that some other population groups might have. They can't work from home. They have to be on site in order to carry on with their jobs. So that's a real curse, if you will, that many of our families are going through. Limited financial resources. We saw that with our case study where, again, the granddaughter was needing to go to food banks to feed seven members of the family, adults and children. Limited financial resources for the Latinx family means, you know, where is my next meal coming from? What about rent or mortgage payments or paying the truck? And if there were any plans to save monies for children to go to college, all of those things are put on the back burner because the money's just not there. Food scarcity is a real issue. A lot of our Latinx families are also going to food banks in many cases for the first time, and that means long waiting periods to get a box of groceries that might hold them for a few days. These are some of the similarities that we see in the African American family in our case study that are also common in Latinx communities across the board. What about their health conditions? These are some of the more common health issues that we find in both population groups. We find diabetes, obesity, hypertension, asthma, large percentages of comorbidities. In the leading cause of death among those two groups, African American and Latinx, are heart disease, cancer, and stroke. For the African American community, for Latinx, death instead of strokes is one of the leading causes of death. The other thing that it's important to note here is that 1 in 5 Latinx persons do not seek care due to language barriers. And that's a drawback. It's an issue that is hurting the overall health of Latinx communities. Next slide, please. Just like we have similarities with African Americans, we also have differences. This picture reminds us of the issues of residency status. Um, African American communities don't have to worry about illegal immigration and how that impacts their living conditions, or do they get care or don't get care, do they qualify for food stamps, do they not, and so on. Latinx families may. And the other big difference is, in addition to residential status, is the whether they're the language and residential is the language, I'm sorry, differences in whether a person is documented or not, and then the language barrier that comes with that. These pictures portray a very difficult period in the life of Latinx families. When we saw the travesty imposed on separation of families and what that cost, it's something that many Latinx communities across the country is still mourning because of the pain and the hurt of separation. And as we speak, there's at least 600 parents that have not been located to reunite with their children. And you can see the impact of that fear and pain in the eyes of these children. But there's light at the end of the tunnel with a presidential strategy, national strategy for COVID-19 response and pandemic preparedness that came out last month. It's a 7-point plan, and I wanted to take out or tease out goal number 6, and that is to protect those most at risk and advance equity, including racial, ethnic, rural, and urban lines. There are 8 subsets to this plan, but I'm going to just point out a couple or 2 or 3 of them that reflect on the kind of expectation that's being built through the new administration. One of them is to establish the COVID-19 Health Equity Task Force. The other one will be expand the clinical and public health workforce, including community-based workers. And another one is to strengthen the social service safety net to address unmet basic needs. And what's exciting about this particular sub-goal is that the government is thinking in terms of providing paid sick leave, childcare support, and rental assistance. And that would be a matter of families qualifying for that and having access to that. Next. What we can do to help. Provide culturally informed messaging. And I'm not just referring to giving brochures and handouts in Spanish, but it's how we communicate with each other. The positivity, the I want to help you, what can I do for you kind of attitudinal position. Number two, inform about locations for testing and vaccines. Inform about community health centers providing COVID-19 specific services. In Dallas, we have, for example, Los Barrios Unidos, which is a community health center. I think they have 3 locations, and they're Spanish-speaking, fully Spanish-speaking providers. And if a particular provider is not fluent in Spanish, they have interpreters, and they just put their arms around their people when they come in. It's a sliding scale, or free services are free. They have promotoras, which are women that go into homes and serve as an extension of the community health services. The same is true in Tarrant County. There are some community health centers that are equipped to serve Hispanic population groups. In particular, they have the Spanish-speaking providers and so on. We can inform about access to food banks, where to go, and you've probably seen where the lines are long, so they would need to understand that there might be a waiting period and so on. What else can we do? We can reinforce the need to wear masks, the importance of social distancing and hand washing. There's been some misinformation, or the interpretation of the information was incorrect, where some Latinx families believe that it didn't matter if you invited other family members who don't live with you to come in and have the birthday party, the anniversary party, the whatever party. Next thing you know, half of them were affected with COVID-19, versus putting a boundary between your immediate family, those that you live with, versus the extended family. And I think that would make a big difference in the kind of scenarios that you read about, you hear about, where people have lost, uh, you know, 3, 4 family members, the mom, the brother, the uncle, the other relative, within 4 to 6 weeks. And that's been very, very destructive to the family. And these last 2 points, I would like to suggest that they're true for any population group we work with during this time of COVID-19, that we must acknowledge their fear. Let's understand that. And we must acknowledge their pain. To that, I would add, we must also acknowledge their value as individuals, and commit to helping them move forward with the circumstances that they're facing. Next. You will recognize the lantern as a symbolic in nursing. It goes back to the mother of nursing, Florence Nightingale, who used to carry a lantern when she was providing patient care. And these are just some thoughts I'd like to leave you with. Keep your lantern lit with faith and hope. Wrap your heart with compassion and love. Take care of yourself first. Then you become a life-giving person. Although you may never know it, you could be the answer to someone's prayer. Thank you.
Thank you so much, Margarita. I think your passion, right, is indicative of the passion of, those nurses out there, and those that are community mental health nurses. We share that passion in social work, and I think it's needed for our patient, in this case, for patients across those communities that are just being so hard hit and negatively affected. And so we appreciate your passion, and I know there's another layer. And so I'm excited to see, what Erin, what you are going to share with us about, what public health even would say about kind of our patient case and just the scenario. What would you guys offer in terms of this review of the case?
Thank you, Jandell, and thank you very much, Margarita, for your words and a very heartfelt message, as well as very good information for all of us. It's been such a delight to hear the perspectives of social work and nursing from my colleagues who I really enjoy the chance to work with. And now I'm here to offer you a little bit of a public health perspective and some things that we can apply to the case of this particular patient and to a lot of people that we work with and know and love in our community. So today I'm going to talk to you a little bit about some of the roles that public health plays in addressing some of the inequities that we talked about today. So first of all, we're going to talk about the magnitude of this problem, looking at a little bit of the data. Then we're going to talk about contact tracing, and then testing access in COVID, and then finally vaccine acceptance. Next. So first of all, I want to start by focusing on the magnitude of this problem and looking at a little bit of data about this. So public health, to take a step back for a minute, public health plays a lot of different roles, obviously, in pandemic and pandemic response. Those varied roles you may have heard about, you all have heard about, everyone's heard about them. Names that we previously only used among ourselves in public health, now suddenly the public knows as well. Things like contact tracing and epidemiology and health education and many others. But in addition, we need to keep in mind that someone in public health is also designing data collection and data systems and analyzing data to be able to provide us with the numbers and information that we read about. And also, that also is a role of public health. And the reason that we have evidence, not just hearsay, about the disparities and the disproportionality that we're seeing is because somebody has analyzed data and reported that. And that has been done by public health statisticians and epidemiologists. So first, we are going to talk about these data that indicate, that show this very wide disparity that we're talking about. So let's talk for a minute about COVID statistics in both our Latinx and African American communities. The story that I want you to remember is that the statistics tell us that COVID is taking the lives of people of color during the prime of their lives. So in Dallas alone, 60% of all positive COVID tests are among in the Latinx community, are among our Latino community members, okay? Even though Latinos comprise only 40% of Dallas population. So clearly a significant disparity. Also, this is really shocking, okay, is that the death rate among those in the prime of their lives, among the working age population, among persons aged 25 to 64 years of age, the COVID death rate is 4 times higher among Latinos than it is in non-Hispanic whites. And African Americans are dying at twice the rate from COVID as non-Hispanic whites. And this is all in Texas alone, okay? In Texas, Latinos have also lost more than twice as many life years to COVID than whites. So if you take all of the years of life lost by COVID so far, and that includes modeling to say, when does somebody usually live, to what age does someone usually live, given all the different factors in a population, okay? So if you take all of the life years estimated to have been lost to COVID-19 by dying prematurely due to COVID-19, 2/3 of those life years belong to Latinos alone. 30% of those life years, or 28%, excuse me, belong to the white population, 10% to the African American population, and 1.5% to other groups. So we again see a disparity in life years lost to COVID. Next, please. So this is why we're starting out with the data, because it matters. Why is it just now that we're talking about life years lost to COVID? Why is it just now do we see the disproportionality of younger people losing their lives to COVID among groups of color compared to non-Hispanic whites? It's because of data, because we didn't know, or we didn't have the right data, or it wasn't being collected in the right manner to be looked at according to race, ethnicity, and then stratified by age early on. So early on, the reports were people are dying at similar rates, regardless of race, ethnicity. Whites, Latinos, African Americans, they're all dying at about the same rate. But now we know that's really not true when you look at the younger groups. The reason for that is initially it was all aggregated. So you had all of the white folks dumped into one bucket, all of the members of the Latino community dumped into another bucket, and then African American community in another bucket, not stratified out by age. So when you look at everyone together, it looks really similar. But when you look at what happens to folks still in that working age group, the disparity is remarkable and frightening. So what are the long-term potential consequences from having such a disparity in death rates at such a young age among people of color compared to non-Hispanic whites? Here's some of the specific concerns. First of all, the economy. These are folks of working age who are still contributing to the economy. So that has real implications for we're losing part of our workforce. Secondly, poverty. If you lose somebody of working age, that meant you've lost an income earner in your family, maybe the income earner in your family. So that's a significant concern for families that now we're on the verge that we're making ends meet out. They lose their income earner, now they're in poverty. Okay. Also, long-term health. Just because you survive COVID doesn't mean you survive it well. We know there is going to be a significant portion of survivors who have been hospitalized previously that will forever be affected by organ damage for the rest of their lives, whose lives may even be shortened due to the organ damage caused by COVID-19. So there's long-term health consequences. So someone who, say, is uninsured, doesn't have access to health insurance through their employer, and we know that people of color are disproportionately represented in jobs that do not offer health insurance. Now we see medical debt and those kinds of things ahead of them and not being able to manage those conditions originally caused by COVID. Also mental health. For those survivors even, who lost family members, maybe numerous family members in some cases to COVID-19, they may be impacted by a future of mental health concerns with this trauma that they've experienced, losing numerous people in a very short amount of time. So those are some of the concerns that we're looking at based on the data. So thank you so much. So yes, read my mind. Next slide. So with this as our basis, looking at the magnitude of the problem and trauma combined into one. Okay, look into that for a new word. So looking at the magnitude of the I said it again, the problem. Now we go into these three pieces that we're really looking at here with public health, and what are some of the challenges and what are the solutions with regard to contact tracing, testing, and vaccines. So let's start here with contact tracing. So first of all, let's think about what contact tracing is. You might not think we have to do that because that term has been all over the news for the last year. But we do because while a lot of people have heard it, they really don't know what all it encompasses. So let's just go through the 5 basic steps of contact tracing to make sure we all are speaking the same language before we go in a little deeper to the specific challenges and solutions for this. So what is contact tracing? Contact tracing requires close coordination between testing sites and the health department to do the following. To first, contact and inform individuals that had a positive test, or the index patient, as we might call them. So those individuals that had the positive test. Then number 2, we ask for information about who they've been around, their recent contacts who may have been exposed to COVID. Then number 3, we notify those contacts that they may have been around somebody, that they have been around somebody who has tested positive for COVID-19. Then number 4, we educate the contacts about quarantine and connect them with resources for testing and quarantine when possible. And then finally, connect them with other additional resources to healthcare if needed. Okay, so those are what the contact tracer does. So it's a lot more than saying you have COVID. It's really goes hand in hand with what social work does. We really can't do it without social work, because social work knows where a lot of those resources are and can address those larger social issues of how am I going to get food if I'm in quarantine? right? What am I going to do if there's a loss of job due to this? What are some other resources, childcare, those kinds of things? If I'm locked in my bedroom under quarantine, who's going to care for my children? So public health and social work have got to work very closely together during the challenges of contact tracing. So also some other challenges we need to think about. As you can imagine, to convince somebody to quarantine is the term used where you're not yet sick, but you've been exposed, whereas isolation is a term we use when you actually have been diagnosed, okay? So to convince somebody to quarantine, I'm not sick yet, but I'm supposed to stay locked away in this room because I've been around somebody with COVID, that this person who I don't know on the phone has told me, like this person I don't know on the phone has told me to do. So this person on the phone, this contact tracer, has got to be able to convince somebody to not go to work, give up wages, stop taking care of duties at home, and stop caring for their own children, and ask others to do these things for them, including childcare, getting groceries, and other necessities. So to do this, you really have to trust that voice on the other end of the phone if you're going to suddenly give up all of these things and do them, okay? So some challenges that come from this are trust, okay? So individuals who have limited access to healthcare or who distrust healthcare might be less likely to trust that voice on the other end of the phone and go into quarantine or isolation. And thus, they often wait until they're in a more advanced stage of disease, whether it's COVID or HIV or tuberculosis or whatever, before they go get tested and seek care. Also, trust is exacerbated, the lack of trust is exacerbated by a institutionalized mistreatment within the healthcare system that some persons of color may have experienced. So we know this is true in the African American community, for instance. So among Black communities, we know there is a distrust of the health system, and government people remain very skeptical of government with regard to health for a long history of reasons, including, of course, Tuskegee, which we're all very familiar with. Also, for instance, there was the HeLa cells, that some of you may have heard about, where we know a woman presented at a world-renowned health institution in the United States for care. Her cervical cells were taken without her knowledge or consent, and they have been used in the pharmaceutical industry and in many other medical industries for many, many things, and have generated a lot of revenue out of those things. This is known, this is widely known in the African American community, this and many other occurrences where significant distrust occurred, where a significant breach of trust occurred. A breach of trust, a breach of respect, and a breach of ethics. So we know that among this particular community and other communities, there is historical reason to distrust what somebody who's calling from the government health department says you need to do, if you don't know this person. Another thing that's concerning with regard to trust that gives us pause is when you think about the significant refugee communities that we have as our neighbors. And so when we have our refugee communities, we have persons who have literally experienced persecution and violence at the hand of their governments. That's why they left their home country to come here. So the notion of the government doing something that's not in your best interest is a very present and real possibility for them. So within our refugee and some of our immigrant communities, trust is also a significant factor in trusting that contact tracer on the other end of the phone. So trust is the first reason we have some challenges with contact tracing. Secondly, we also have a challenge with the ability to just meet basic needs so sick patients can isolate, or so exposed contacts can quarantine. So we have to work closely with social work to be able to make sure those needs are met, and work closely with and hire our contact tracers from local populations who might be better able to anticipate those needs than somebody who lives across town in the health department, works at the health department, and is a voice they're unfamiliar with. And then finally, shame and stigma are significant challenges in contact tracing. So social media and misinformation generate a lot of stigma about infectious diseases across the board in all communities. And there are significant adverse consequences for stigma of infectious diseases of all kinds. We have seen this for decades, whether it's HIV or TB and now COVID. And so that can include delayed diagnosis, interference with efforts to prevent disease transmission, ultimately leading to increased disease transmission, and also a decrease in seeking care. So a solution to the contact tracing, I'd like to share with you a few solutions. I'd like to first illustrate it with a true story that I read about. This is what contact tracing can look like when it's done well and by a member of the community. So this is a story of a contact tracer from an Iraqi refugee community in her town in San Diego. And the contact tracer calls an Iraqi woman to say, hey, your 18-year-old daughter or your teenage daughter tested positive for COVID. She needs to quarantine. You live in a small apartment with a large family. Yes, okay, you know what? We can have her quarantine in a hotel. Okay, that'll make it easier on your family. So let's get her to quarantine, to isolate in a hotel and alleviate some of that burden on your family. We can get her food, those kinds of things. This incites terror in the mother, because what does it bring the mother back to? It brings her back to the fear of separation from her family. When she fled Baghdad and a member of her family was killed, and they had to stay very close together for fear of family separation, either due to bombing or kidnapping. So the mother expresses a general concern, and the contact tracer immediately knows where that concern is rooted. She knows it's rooted in fleeing Baghdad because she herself had a similar experience. She knows the shared trauma of fearing family separation, and that saying that they can quarantine or isolate her daughter away from the family in a hotel is not going to go over well. She immediately knows that that will not happen, and she works with the family to figure out a way for the daughter to isolate in the family small home. That's when contact tracing works well. We have a member of the community who understands the needs of the community to be able to provide that education and that support in a way that will be real, that will make sense, and that will be practical and feasible for that other member of the community who they're reaching out to. So we suggest that contact tracing comes from people when they get tested, also to facilitate trust. So at the point of testing, let's give people information about contact tracing. So whether or not that test comes back negative or positive, we'll have that information, but let's do it at the point of testing, because right now you're tested, and then if the test is positive, you're called with no anticipation that this call might happen from the contact tracer. So at the point of testing, it is important to give people, here's the number that might come up on your phone. You need to answer it. They're from the health department. You can trust them. Or they're a community health worker from your community who's employed by the health department. You can trust them. When you get this number on your phone, you need to answer the call, and it's someone you can trust. That education needs to happen at the point of testing. Now, we realize healthcare workers don't have time. We've seen the lines to get tested in some cases. So what has to happen is a health educator, a community health worker from the community, preferably, needs to be present at that testing site, giving people that information at the point of testing. Once they're tested, they get pulled over in the line to let the next person come up and go through the clinical procedure for testing, while that person who was just tested is receiving the information from that health worker. So those are a few things that can be done. Also, at the point of testing, names of other contacts that the person is commonly around can be provided, their contact information, so then they can be informed and readily notified, and then we can reduce the lag time, the time for transmission. So those are a few things that we can do during the point of initial testing for the purposes of contact tracing. So now we go to the next slide about community testing. And so I'm gonna go ahead. Yeah, that one, that's the slide, the map. Perfect, thank you so much. So we have this slide showing this map here. And this map that you're looking at is a map of Dallas. And the red area, it shows the communities within the community, the larger community, that have the most risk factors, okay? So those are areas in Dallas that have the highest number of risk factors for COVID-19 infection, okay? So note where that is. It's in South Dallas, okay? Next slide, please. Now we have here another map. This map was created by Parkland, okay? They have a research group that creates these fabulous maps. And this map is a vulnerability index. Where you see the darker colors on the map, that shows the most vulnerable populations, to COVID. Now, this is not only health risk factors, but this also includes social risk factors. This includes housing, this includes access to healthy food. This includes employment, poverty. All of these things are included in this vulnerability index. So note here the most vulnerable communities to COVID. Now, notice those orange and yellow spots over that. Those are the outbreaks. Those are the hot spots overlaid with the most vulnerable communities. You can see then that the most vulnerable communities have a significant proportion of the outbreaks in Dallas. Next slide. So we would anticipate that testing sites could be appropriately located in that southern area of Dallas where we saw the most vulnerability, the most risk factors for COVID, and in fact, some of the worst outbreaks for COVID. So let's look here at this map that shows us where those testing sites are located in Dallas. So we see the map on the left that shows the percent white in a community, okay? So the more purple, the more white folks in that area of Dallas. So where you see the black dots, that's testing sites. So we see the testing sites located in this very white area of Dallas. Now we go to southern Dallas where we know there was the greatest vulnerability and the most risk factors for COVID, and we see few testing sites. Okay, let's go to the map on the right where we see the more green the area, the more money, okay, the higher the income. The darker the yellow, the less income. We see the less income again in that southern area of Dallas where we had the most risk factors, where we had the highest vulnerability, where we had the fewest white people, the most people of color, and also the fewest testing sites. Let's look what the testing sites are. We can see the testing sites are not there. So where we have the greatest chance of transmission, the most vulnerability, we have few, if any, testing sites. They're located in the areas that have the least vulnerability, the most white folks, and the most money. I think that speaks for itself. Okay, so what do we do about it? What do we do about testing? Okay, so a few other challenges I just want to cover with testing is we have a cost issue. Now, there is information out there that that cost has been removed, but people are still very afraid of the cost, okay? There's also another reason to be afraid of cost. We have people who have concerns about being able to get tested or cannot get tested due to location or other challenges. So what do? The practice is go to your primary care provider if you do have access to one, and they run every other test in the book to rule out COVID. What happens then? You get a huge medical bill. This is getting around. This information is traveling. I went to the doctor. I couldn't get tested for COVID. They tested me for everything else to rule that out. I got a medical bill. Okay, so this is a fear. This is a real thing. Again, going back to location, a challenge there is not only can I get to it, can I physically get to where it's located? Can I take 3 buses and 2.5 hours later get to it if we don't have immediate transportation? Or can I take off work to spend the time standing in line or waiting in line or taking the 3 buses it takes me to get there? But also, do I feel comfortable? If there is no site within a few miles of my neighborhood and I have to go up to that very purple region on the map, Highland Park, and that's not near where I live and I'm not comfortable there and I'm afraid of how someone's going to see me if I don't have as nice a car, or if I'm in poverty, or as a person of color, how will I be viewed in a very white neighborhood? I'm not going to go there. So there's comfort, there's transportation, there's all kinds of aspects of access, and also the information that testing is in fact at no cost. So some solutions to this. Wow. Hello, ask the people affected. This is where another aspect of public health comes in. Public health researchers, they know how to do community-based participatory research, and they have contacts in those communities. And they can go to their trusted contacts, say, hey, can you help us find out where people think the testing sites should be located and what kind of education we can do to get out this word about the testing sites, and go to the community members themselves. I've done it a lot for public health research. We found out fantastic information we never would have known otherwise about the places that people most trust. It might be a restaurant, it might be a place of worship, it might be a community center, it might be a park. Okay, so find out where we can go, where people go, and we'll go to that site, be able to use it and trust it. Ask grassroots leaders, ask the leaders in the community, and also listen to their counsel. So instead of assuming something, ask and then listen, and then actually place the testing site there. We need to make sure people know that testing is free, that we have the Families First Coronavirus Response Act that eliminated costs for COVID testing. And this goes beyond the local community with testing. This goes into the federal government. We have got to have enough testing sites. We have to have sufficient testing to be able to set up these testing sites. We have to have enough tests. We have to have enough staff. We have to have enough PPE, personal protective equipment. We have to have enough lab capacity. So we can establish more sites, right? And we have to make it a priority at the federal level to have tests that give us a rapid response. 24 hours is too long to get a test result back, because then it's another day or two to contact the individuals. They've been in their multi-generational family, perhaps, with multiple people exposed in that amount of time. So we've got to have rapid testing to mitigate the transmission that's occurring in the most vulnerable communities. Now we go on to vaccines. Next slide, please. Okay, so vaccines, opportunities, challenges. What do we have going on? Very similar to what we just talked about. Okay, so I'm not going to repeat what I've just said. We have similar issues of trust, okay? And it's already manifesting itself with who's received the vaccine. So far, over 4% of the white population has received the COVID-19 vaccine, whereas about 1.9%, so less than half of the African-American community has received vaccines, less than half compared to the white population. And also 1.8% among the Latino community has been vaccinated. So we see that already the white community has been vaccinated at over twice the rate. Now, here's why this is particularly unusual, because healthcare workers have gotten the vaccine first. Well, among our healthcare workers, 41% of our healthcare workers are people of color. 52% of our healthcare workers in long-term care settings are people of color. So you wouldn't expect this degree of disparity. And this is why the public health research community is very concerned, because these are folks who trust science, who work in healthcare, who understand science. And we see a disparity already in who's getting the vaccine, who's accepting the vaccine. We have significant trust issues, significant education issues already, even within a very well-educated community that is a very well-versed in science. So already we're seeing challenges. So we're very concerned about the long-term effect this could have, what this means long-term for vaccination rates within our communities of color. So we have to educate everyone, even if they are a healthcare worker and know science well. We have to have that education provided by somebody from their own community who they trust, because of that historic discrimination. Almost everybody who is a person of color knows somebody who's been discriminated against in the healthcare system. Everybody is aware of the historical significant instances of discrimination, and such as Tuskegee. So we have got to make sure that education still happens, and it happens with folks who people trust. So that's one thing we need to think about. Also, we need to have what was called by the president of the Urban League in Philadelphia. I love this term, trust messengers. She coined the term trust messengers. We have to have trust messengers for the community. We have to have trust messengers working with public health about location, about transportation, about how to work this into the employment setting. And so people can get the vaccine outside of their hours of employment, so they don't have to take off work and lose those hours of wages. So they can get it after work or outside of the regular hours of work. And scheduling, when do we have this? When is the shift work, for instance? When are the shifts in this community most likely? Do a lot of members of this community work in a particular employer? When are those shifts? When can we have these vaccines, this vaccine station set up? How can we do the scheduling for this? Is it electronic? Do people have smartphones? Is it another way of doing it? Is there a better way to do scheduling? Do we do door to door? Do we talk to people as they're coming out from work and physically sign them up for scheduling a vaccine? How do we do the scheduling? We're going to have to make sure there are vaccine centers in all of these places. We saw on that map earlier, we had the most vulnerable people. We cannot repeat what's happened with testing, where we have testing sites where people are less vulnerable and more white. We have to make sure we have vaccine sites where folks are more vulnerable, and also where there are significant communities of color, because again, people of color are the folks who are dying from this at the prime of their lives, disproportionately compared to whites. So it is a benefit to our economy. It is a benefit to family economic prosperity, to prevent families from going into poverty, if we make sure that that breadwinner does not contract, become seriously ill or worse with COVID-19. So it is of everyone's benefit to consider the most vulnerable communities when we think about testing sites and vaccines. So to finalize, we do have some good hope. Just like Margarita mentioned with the 7-point pandemic plan, we also have the 5-point vaccine plan that was just came out from the Biden administration. And President Biden said, quote, "We are going to make sure there are vaccination centers in community hardest hit by the pandemic, in Black and Latino communities and rural communities as well." And I'm hopeful that that will be the case. And I'm hopeful that with our new administration, we will be able to have the increased testing sites, and these increased access for vaccines that we so need for all people. Thank you. So that's the public health perspective. So I'll turn it back over now to Patty, because I think that we've all shared our various perspectives.
It was wonderful. I mean, powerful, very important information, magnificent presentation. Thank you all very much. What we're going to do now is open it up for question and answers. Presenters, please feel free to answer the questions as appropriate to your discipline, if you don't mind. And I can see that we have one question right now, and let's see. This is, are the COVID death statistics that you mentioned from the CDC, and do these include those that died in the hospital, nursing homes, and or at home?
Yes, those statistics were published by the Dallas Morning News. I actually worked with them on that article. It was sparked because I've been ranting about this for months, and I ranted about it finally on Instagram, and that was seen by Anna Cushman, who is the chief science writer at Dallas Morning News, and she's like, what's going on here? And so we talked about different data sources where we could actually get to this information in Texas, and Dallas Morning News did, in my opinion, a beautiful job at obtaining those data sources. Yes, there was CDC data, there was a variety of data sources, there was state data, and there was other data, and yes, it includes everyone that you are mentioning who died in all of the different locations. So this is very well analyzed data from an esteemed researcher, statistician out of UT San Antonio, and it was stratified appropriately. So yes, this is reliable data, and it does take into account all of the different areas you're mentioning.
The data to the charts that I started out with are also from the CDC. So, and those were the national numbers. Yeah.
Great. Now let's see. One person wants to know if they could have access to the graphs and the information that you shared.
Erin, probably your graph.
That me?
Probably. Yes, I think so.
Yes, absolutely. That was all publicly available information. I encourage you to go to just Google Parkland PCCI, and you'll get to their institute that is creating a lot of these fantastic maps of Dallas that are showing the different testing sites, vaccine sites, the vulnerability index, the different hotspots. So that's where a lot of the maps I showed came from.
Thank you. And the next question, based on known disparities, why aren't the public health officials fighting for these neighborhoods?
I think they are.
Okay.
A lot of the information I used actually came from American Public Health Association and of the president of American Public Health Association, Dr. George Benjamin. Dr. Benjamin has not minced words. He is a person of color. He is angry at what is happening, and his words come from what his constituents, so to speak, are saying, what the public health community is saying. Everyone I know who works in county public health feels as passionately about this as every one of us on this panel. Where the limitations come in is the federal government. There were a lot of limitations there because of public health. The way it works is it funnels from the federal government to the state government to the county level. So if there is a bottleneck in any one of those levels, whether it's policy or funding or any other kind of resources, you're stymied at your level locally. So I know that public health is angry, but what happened was the national pandemic plan that had been in existence for 16 years, that was started by the George W. Bush administration in 2005, 2006, was built beautifully, protected and fostered by that administration, handed over with kid gloves to President Obama's administration. Again, bipartisan. This was not a partisan issue. Pandemic was never a partisan issue. This existed This existed for 16 years through 2 administrations. So we had a pandemic plan, but then when this particular pandemic occurred, there was no longer the plan. And so a lot of things that would have been there with regard to resources and vulnerable communities were no longer planned for, because there simply was no longer a plan. So we had to turn it over to states and localities to do a lot of things on their own. That's not how public health is set up. Pandemic preparedness and response is set up at the federal level in public health. So this was a paradigm shift, and we aren't set up for it. So it does require a lot on the federal level.
Mhm.
Thank you for that answer. In the chat, there's a question about the vaccine. What is being done to build that trust in the community? Trust to take the vaccine, I presume.
Is that a me question? Is that a public health question or a social work question?
I think it might be public health or social work. I mean, is there trust being built related to people's willingness to receive the vaccine?
Yeah, I'm not sure about the, from the healthcare perspective. I know social workers that are in healthcare settings are trying to, build rapport with clients. So a lot of what Erin talked about, right? You trust me, you trust the information that I have. But in terms of being in homes, social workers working with, families and other systems, I'm not sure, if a lot of the hurdles and the unfortunately historic discrimination in the healthcare system is easily able to be overcome. And it's a really personal choice for a lot of people. But I think social work, case managers, those working in hospitals are definitely trying to be that bridge in terms of, hey, may not trust necessarily the larger system. You trust us, we're working in this system. We might be able to, you have information that you trust.
I think it would be appropriate to recognize the role of the community health workers. They're certified CHWs. Baylor Scott and White has a tremendous network of those kinds of persons who go to the homes with the intent of establishing trust. The way they're deployed by different organizations, not just Baylor Scott and White, is those persons are selected on the basis of their knowledge of the community where they render services, and that includes cultural norms, the language, etc. The underlying purpose is to establish trust because they know each other. And there's more and more emphasis being given to these kinds of healthcare extenders, if you will, from hospitals, from clinics to the home, to the families. So that's an important development that I think is gaining more and more momentum.
Great.
Yeah, I just want to echo what Margarita is saying with regard to community health workers. I was going to say the exact same thing. This is a certification. They are trained lay health educators. They know their communities well. The DFW CHW Council is working closely with Parkland to make sure that CHWs are at every part of this pandemic response, and that includes vaccine education. We have numerous large grants in our DFW area that I know the DFW CHW Association is working with, as well as other healthcare providers. And this is a grant to do exactly what we're talking about, is to deploy community health workers to provide vaccine education in marginalized communities in Dallas-Fort Worth. So this is happening. Also, I think we have to remember, and I'm not giving anyone an excuse by any means, because anyone who knows me, I don't mince words about this topic, but we are pretty early in the vaccine distribution phase. We are very early in a new presidential administration, which is very relevant because, like I said, this all starts at the federal level when you're talking about pandemic response. Because disease doesn't know where county borders start and end, where state borders start and end. Pandemic response is coordinated at the federal level under public health. So this has all been we're very early into this. So I do encourage everyone to have faith. I really believe that we're going to see community health workers have a spotlight on them in a way they have never before. At least I hope. I think it will. They are being deployed, and we're going to see this education response ramp up very soon under this vaccination plan.
Great. I'm having some comments versus questions. So one person wants to know how Tarrant County is doing.
In what regard? How they're doing?
As it relates to the COVID numbers, I presume. The data, perhaps that, again, the resource that you mentioned, Erin, might be the helpful resource for that person to find more data.
Yes, I encourage you to look at the local data. Look at the state dashboard. There's a state Texas Department of Health and Human Services COVID dashboard. If you Google it, it'll come up and you'll get to see COVID data for your own county. That includes hospitalizations, new cases, all of that you can see by county. As far as the vaccine response, Texas is number 30th out of 50. I don't know what factors went into that measurement, but that was a recent national poll that came out in terms of vaccine distribution. So that's overall how Texas is doing. I will say that nationally, North Texas is considered to be one of the better places. And I know it feels hard to believe for those who have tried to get a vaccine and they see that there's literally right now, there are 500,000 people in line in Tarrant County.
Yeah, there was one question regarding how, with the current shortage of COVID vaccination dosages, should the racial disparities in how COVID affects our communities significantly affect how we are prioritizing who should receive access to the vaccine doses that come next, or the next doses?
I think that's a significant concern for the public health community, is making sure that those individuals in communities of color are prioritized for exactly the reasons that I mentioned. They are dying earlier. They are losing more life years. This is a crisis of great magnitude in that particular community, and the communities of color relative to the white community, if you look at the ages at which people are dying. And I am not by any means diminishing the life of an older person, not at all. But if you just look at the overall implications of life years lost, we cannot ignore that community any longer. We have got to have vaccinations there because the transmission is happening quicker and more severely because of housing, because of employment and other reasons. So they must be prioritized. I think public health has made a pretty clear national statement about that. From our national association, what actually will be employed to do that, I don't know. I know it is part of the Biden plan. And they have said that they will be, communities of color and rural communities will be prioritized, but I don't know exactly what that looks like yet.
From Facebook, we have a question. I'm a caregiver myself. Let's say I'm not. Can I say I am a social work intern and get vaccinated?
I'm not sure about that. I know social workers are, considered kind of towards the front of the line, right, in terms of frontline workers. So I'm not sure about interns. That's a good question. I could try to find out though.
It's an honor system. When you register for your vaccine at the county, it's an honor system as you put in your profession.
Right.
So
put you on A1 or AB, right?
Yeah.
Yeah. Okay, from another one from Facebook, what is being done to help overcome loss of income fears? I am personally just returning to work and am very resourceful. I am waiting for short-term disability or unemployment. The response I am getting is, you only need to be off 14 days. I was sick for almost 2 months. And because I was positive, I had trouble getting any care except at the ER, but I was not sick enough to be treated there. This is a scary gap. We want people to be safe, but if they have to be scared about losing income, that's difficult. Mm-hmm. So anybody has any of you dealt with that issue as far as fears and over the loss of income related to COVID? Perhaps social work or Marguerite?
Yeah, kind of narrow the question down. So what's being done to help? And I think, it's really a case management basement. I don't know if there's, a larger strategy in terms of addressing income loss. But there are, particularly in hospitals, social workers that can try to help address your particular situation. And the question kind of disappeared. So I lost it.
I'm sorry.
But yeah, so trying to work with your employer to be able to make sure that you do qualify, to try to be the advocate right in the hospital that explains remember, Not just, hey, on paper, this person looks like they need to be here this amount of time or that amount of time, but the social worker is there to advocate, to say, well, we have to consider the whole system, right, that this person is operating in, what they need to be able to not lose those benefits. So
Excellent.
tough situation.
It's very challenging. Are there currently plans in place for more testing and vaccination sites in those red areas of South Dallas? And what are the barriers to get these set up? Does anyone have any exposure to that information? Perhaps public health?
Barriers to set up what, Patty?
Oh, I'm sorry. Are there currently plans in place for more testing and vaccination sites in those red areas of South Dallas? And what are the barriers to get these set up?
Thank you. Sorry, I missed part of that. You said it. I missed the geographic area, so thank you. My understanding is that yes, there are plans underway, but those plans were dependent upon the federal level of getting, everything we need for testing ramped up, and to get more of those, make sure we have adequate production and distribution and accuracy of the rapid tests. But now we're seeing more and more of those testing sites going up already. So I think that we'll see more and more of that, we hope. And as my understanding is, there's also plans, particularly in Dallas, for vaccine sites in South Dallas and in the communities you saw that were most vulnerable. I can't speak to where they are in the planning, but the last I knew from a statement that County Judge Jenkins released, they were very much in the process of planning for those areas.
Excellent, thanks. Now there's a question. I work with the Hispanic community. So how can I get information or of resources to share with my patients? Margarita, do you have information, or anyone on that?
Information about what? I'm sorry.
Information and resources to share with their patients in the Hispanic community related to COVID and testing sites, immunization times, those types of things, I believe.
Erin, is there a centralized go-to link for that kind of information?
Yes, Tarrant County Public Health has all of the vaccine information and testing information in multiple languages. They have flyers for each of the major languages that we see in Tarrant County. So there is a significant body of literature that's already been translated into Spanish. Very nice flyers about it. Also, if you want like county specific information about where to go, there was one that just came across my desk a couple days ago. So I know it's still, it's still out there, it's still happening. And then if you want just general information, education about testing and vaccines and other aspects of COVID, the Centers for Disease Control and Prevention has, again, many flyers in different languages on their site that you can download.
Great. There's a repost of the earlier question to clarify. How can we as healthcare providers help to decrease bias or unconscious bias when providing care to our patients of color? And how, that's part one. And how can we inform and educate our fellow coworkers of this bias? And the rest is a statement. A lot of people of color are often dismissed and receive less care than the whites, which leads to increased mortality, including with COVID. I see this often as a Hispanic nurse in the ER. So yeah. The first one was the bias question. Yes, go ahead.
All right, so those are great questions, right? So we talked about not necessarily the client being the issue, but as Erin laid out all of these disparities, there's a reason why things are set up in certain communities. We have things in our society, right, that rear their ugly heads, and healthcare is no different, right? So there is bias, and there's no easy answer to it, but people have to interrogate the sources of their information. That's how bias is created, right? The things that we consume, the things that we watch, the things that we read, the things that, we hear from those in our families. And so as a healthcare worker, you don't divorce yourself from all of those things. Unfortunately, when we talk about unconscious bias, you have a reaction based on the things that you've learned. And so what you have to do, what your coworkers have to do is when they're thinking about Latinx patients, African-American patients, Indigenous patients, they have to feed themselves information that will get rid of the bias, right? So if you think negatively about those patients of color, you have to start feeding yourself with things that are positive about them. And so that's a really personal work. A lot of people are not committed to that. But it's a lot of questioning. And so I would, encourage you, if you do have to bring up things like that at your place of employment, what do you mean by that? Right? If you hear somebody say something that might be a microaggression, they might feel a certain way about a patient. Oh, this patient is really just here, to try to get meds. They don't really need this. Oh, they should be okay. Well, we don't need to do this. Well, why do you think that? Right? To help people interrogate the beliefs that they have. Really not a training class or, go to this program and you can get rid of bias. A lot of it's going to be that interpersonal work between coworkers. So I appreciate that question.
I would like to add that we start with ourselves, like you were saying, Jandell, and do an introspective analysis of our own belief systems and our own prejudices and how we react to that. And then the best way you can get others to emulate is to be a role model with positivity and get the discrimination out of your system, and others will see that and hopefully will learn from you how to modify their own behavior and belief systems. And that's a powerful tool. Sometimes we underestimate the power of setting an example, but that's one of the most effective ways to change perspectives, particularly if there's a conflict.
I just want to put in a quick plug for cultural humility training. That's not cultural competency training, cultural humility training. I'm sure any of my global health students watching are like rolling their eyes or nodding their heads or rolling their eyes or something right now, but I'm a big believer in cultural humility training.
Thank you.
Exactly.
Now this is for Dr. Trevino. From a community nursing perspective, do you find that more Black and Latin patients are complying with their care regimes now that contracting COVID-19 is a concern? As it was presented, many minorities have diabetes, obesity, and cardiovascular disease.
I think we're going through a transitional period with all of these chronic conditions and what to do about them. Hopefully, as we traverse this journey in terms of, so what does it mean to me? Let's say I have comorbidities, I have obesity, I have high blood pressure, I have heart disease. What are the implications on top of COVID with all of that? I think it's it's an awakening time for our own people, for the Latinx, for the African American community. One of the best things we can do in terms of servicing them is to equip them to do self-management. You teach them, you expect them to learn how to do better with diabetes, with obesity, not just say, well, you have to lose weight. So how? Give them the how-tos and support through education and opening pathways for them to enter the healthcare systems where they should not be afraid. There should be trust to walk through the doors of a clinic, of a hospital where they need the care without being afraid that, by golly, I know I'm going to face discrimination, but I'm going to have to do it. So it's a cyclical thing. Not only should the patient themselves, the patients effectuate change, but then we as advocates also need to do what we can to improve the other side of that equation, the providers. And one quick example, I was interpreting for a patient in a pediatric setting, and the intern told me, well, this woman, being Latinx, has a speech impediment. And I said, well, okay, I'll keep that in mind. We go into the examining room. The lady was as fluent can be. After the examination, as I approached the intern and I said, I thought it was a resident. I said, I thought you said she had a speech impediment. I didn't see any speech impediment. And he says, oh, well, she doesn't speak English. And so I said, okay, in that case, you have a speech impediment as well because you don't speak Spanish. And that's the kind of, and I don't take pride in that, but the point is, we can't always blame the victim for some of the disparities. We have to own and effectuate change.
Many applause just happened on the screen there. Thank you, Margarita. There's there's one comment and then a couple last minute wrap up questions. And thank you for everyone for adding this. Also, one comment is that the Texas Nurse Association recently had a CU offering on implicit bias and what every nurse needs to know. So that's a good point. The other comment, I am hearing some preliminary data of healthcare workers who are younger females with low education, low income groups are refusing the vaccination regardless of race and ethnicity. More education is definitely needed so all healthcare workers and general population can make informed decisions. Is that anything anyone's experienced?
Yeah, it's the anti-vaxxer movement.
Yes, okay, thank you. Okay.
Thank you, anti-vaxxer.
Well, thank you for responding. Yeah, that's very dangerous. Okay, now a couple of things. Can Aaron provide the data link into the Parkland in the chat if possible, or we are having follow-up emails with everyone, so it is possible we could send some of this information out afterwards, because someone else is asking, can we get a list of all the wonderful faculty presenters today and how to contact them? Also, any slides or links as appropriate. And I'm sure you'll be able to do that. Now, in the chat, we have lots of the resources, as I mentioned earlier. If you didn't get the case study or the article or your pre-work, it will be available. People are also in the link posting the evaluation information so that you'll be able to follow up and get your post-conference evaluation. Well, we're going to have a second part to this event where we'll be discussing different perspectives about the impact of COVID-19 and the end of life. We'll email all registrants the information about our second event and follow up with any of these materials you're asking for today. The evaluation link is now posted in the chat for your easy access. And I want to thank you all the wonderful speakers for presenting just such timely and important content. Thank you for everyone attending on the Zoom call and the Facebook. I hope that you learned and feel a lot of growth in this opportunity. Speakers, any last minute parting words you'd like to make? We have just about 2 more minutes.
No, I'd just like to say it's been an honor to work with Margarita and Aaron. And, you know, we hope today you guys really see the strength of collaborative practice, and it's really what's needed. And so I really appreciate your perspectives. Ladies, thank you.
Thank you, Jandell. The feelings are mutual. It's been a joy to work with you and Aaron.
And I'd like to give a great thank to, again, to each of you and the planning committee. Everyone has been working so hard. Tracy, you've and Becky have worked so hard. So applause all around. Thank you, everyone. We appreciate your time, and you'll be getting more information from us very soon. Thank you.
Thank you, Patty.
Thanks, Patty. Bye, everybody.
My pleasure.
Thank you, everyone.
Bye-bye.